Hello and welcome. My name is Shekhar Saxena, and I'm so glad that we are gathered here today for this crucial discussion on reinventing mental health. I would like to welcome all of you, including our panelists, on behalf of Dean Michelle Williams, who has consistently prioritized efforts to improve mental health care. I believe we can all agree on the starting point. Our mental health care system is broken. We are not reaching enough people. We are not providing the right care, and we are not alleviating the tremendous suffering that mental illness causes individuals, families, and communities. It is past time to address these failings, both in the United States and around the globe. I am hopeful that this discussion will bring forward ideas that can help catalyze change. There is no one better to anchor the panel than Dr. Tom Insel, the former director of National Institute of Mental Health and author of the new book, Healing. I have known Dr. Insel for almost 20 years, and my respect for him has grown exponentially over this time. As you will hear today, he brings sharp insights into both the mental health crisis facing our society and some promising solutions. Both are important because there are solutions. We do not have to accept this broken system. We can demand better care. We can do better. I'll let him and other illustrious members of the panel dive into those solutions. But first, I will share a few statistics that speak to the depth of this crisis. In the United States, the Center for Disease Control and Prevention recently reported that more than 40% of teens feel persistently sad or hopeless, and 20% have contemplated suicide. Among adults, 1 in 3 report symptoms of anxiety and depressive disorders, with millions unable to access counseling or medication. Globally, a Lancet panel led by another one of our distinguished panelists, Dr. Vikram Patel, recently reported that there is a worldwide crisis of depression. Across a lifetime, anywhere from 10 to 40% of the individuals will have at least one incidence of major depression, and the vast majority of these individuals are neither identified nor provided care. It is evident that our mental health system is broken, but it is never too late to act. In some ways, this could be an excellent time to accelerate action. COVID-19 pandemic has led to an increase in awareness, and for the first time, the State of the Union address in the US referred to mental health. Globally, World Health Organization is planning to publish a new report on mental health in June this year. Let us discuss what is needed and how to achieve that. With that, I'm pleased to introduce our moderator, Ritu Chatterjee, a reporter on National Public Radio's Health Desk, who specializes in covering mental health. Ritu, over to you.
Thank you, Shekhar, for that introduction. And hello and welcome, everyone. So as Shekhar mentioned, we're here today not so much to dwell on the problem, but to actually talk about solutions. And I've been covering mental health for several years now, and it does feel like we're sort of at a turning point. As again, Shekhar mentioned the State of the Union address, where President Biden announced a new national mental health strategy, including significant investments to expand the number of providers and establish mental health care in non-traditional settings like libraries, community centers, even homeless shelters. And as some of you may know, that the 988 mental health crisis hotline is expected to launch in July. And technology is changing how we think about care and how we receive it. And that's certainly become very evident during this pandemic. So as we mark Mental Health Awareness Month here in the US, I'm joined by a fabulous panel. So I'll start by introducing them. We have with us Neha Chaudhary. She's a psychiatrist at Massachusetts General Hospital and Harvard Medical School and Chief Medical Officer of BME Health. Christine Crawford is a psychiatrist at Boston Medical Center and Boston University School of Medicine and Associate Medical Director for the National Alliance on Mental Illness, or NAMI. Thomas Insel is the former director of National Institute of Mental Health and the author of Healing, Our Path from Mental Illness to Mental Health. Carlos Larori is a member of NAMI's board of directors and a nurse practitioner specializing in psychiatric care. And Vikram Patel is the Pershing Square Professor of Global Health at Harvard Medical School with a joint appointment at the Harvard T. Chan School of Public Health. This event is part of the Dr. Lawrence H. and Roberta Cohn Forum series. We thank the Cohn family for their support. And we've already received some great questions from our viewers, and please feel free to drop any additional questions into the YouTube comment section, and we'll get to as many as time allows. So I want to start with Carlos. Carlos, you have lived experience with serious mental illness. Could you tell us about how you first received a diagnosis and what your path to recovery was?
Sure, Ritu. Well, I first noticed changes in my mental health in adolescence. I had excelled in high school and gained acceptance into an early admissions program for medical school. However, during college, I transformed from a promising young scholar into a gravely ill person. I had begun hearing voices and became increasingly preoccupied with religion. And by the end of my senior year, I was isolated from my community, neglecting my hygiene, and rambling to myself. Fortunately, a friend I had known from home was also studying at the same college, and she called my mom and said, "Carlos's behavior's off. You need to talk to him." My mom arrived on campus the next day, and I had a meeting with her and my academic advisor. And my advisor said, "Carlos, you're an adult. You have a right to privacy. I don't have to discuss anything that has happened to you on campus with your mother." And in a rare moment of insight during my psychosis, I said, "With all due respect, Dr. Clark, I have a Cuban mother, so I've never really had a right to privacy." All kidding aside, that was a turning point. That opened the door for an honest conversation about my mental health and was the first step for me towards getting help. Ultimately, it was family and my community that first facilitated my path towards recovery. From there, we saw a team of mental health specialists, of course, and I was ultimately diagnosed with adult onset schizophrenia. But fortunately, I've been able to recover and live a life filled with work and relationships because of family and peer support and a sense of purpose. Family provided for my basic needs and advocated for me to get care, as well as encouraged me to share my story and attend support groups. Meeting peer role models with shared lived experience allowed me to see that recovery was possible and forge deeper relationships with others. And finally, helping others and advocating for mental health has provided me with a deep sense of purpose, allowing me to cope with my illness and make sense of my adversity in a healthy and altruistic way. So that's how I first got the help I needed and some of the important supports that have facilitated my path towards recovery.
Wow, that's incredible. And thank you for sharing that. So I want to turn to Tom. Tom, Carlos just spoke about the importance of family, purpose, peer support in recovery. Are those three elements the standard of care for the mental health care package today? And how do we begin to get this to people who really need it?
Well, thanks, Ritu. It's the right question to ask, and I must say it's a real privilege to be part of this panel. I think we've got everybody on the panel who can speak to these issues about what it takes to reinvent mental health care and transform what we do. It's important to realize that when Carlos talks about recovery, and he talks about the importance of peer support and family involvement and finding a purpose, that's not really at the heart of what we talk about when we talk about healthcare. Carlos is one of the heroes of my book, so I know his story well, and it was incredibly helpful to learn from him. One of the things I did in trying to understand recovery was to talk to people on the front lines, people who had recovered, people who were providers helping people recover. I had a great conversation with a psychiatrist on Skid Row in Los Angeles who said to me, recovery it has to be our North Star. And I said, okay, that's great, but what do you mean? And he said, well, it's really easy. It's just the 3 Ps. And I thought, well, all right, there's Prozac and there's Paxil. And I was trying to figure out what the third P was going to be. And he said, look, it's easy. It's people, place, and purpose. People, place, and purpose. Carlos just took us through that from his own personal experience. But having social support, and that can include family, it can include peers. It's knowing that someone has your back, having the sanctuary, the place to recover. So it's hard to recover in a homeless encampment, hard to recover in jail or prison. So having a place that supports your recovery, and then having a purpose. And I love the way Carlos talked about the importance of becoming a peer, of giving back, of finding purpose from his own lived experience. That's such a powerful part of this journey. And one of the things we've learned is that in many ways, helping others is more therapeutic than even getting help from others. It's really a very powerful experience. Not something, though, that we support in our healthcare system. And to your question, this is really the challenge, is we have these 3 Ps, which we know are critical to recovery. And yet our $4 trillion healthcare system doesn't pay for that. You have clubhouses that support recovery, but clubhouses are fundamentally funded through philanthropy or through having a bake sale, whatever it takes. We have to rethink. If we're going to reinvent mental health care, we ought to ask, what are we paying for? What's in that scope of healthcare? How much is mental health care aligned with our goal of mental health? Or is that really a question that we need to explore, that we need to actually not just reinvent mental health care, but reinvent what we're meaning if we're aiming for mental health, so that mental health care has that broader scope that helps people get those 3 Ps.
As you wrote in your book, right now the approach is more at fixing or like addressing sort of a crisis situation.
Yeah, if you sat back and said, "Hey, let's design the most expensive, most intensive, least effective system we can," it's not too different from what we have today. And the need to reinvent that, as Shekhar said, it's a broken system. We're past time to do this reinvention.
So Neha, I want to turn to you. You work with youth, and as we've seen the media, the Surgeon General put out an advisory. Shekhar talked about sort of the toll of the pandemic has brought a lens on what children and teens and youth are struggling with, but some of the solutions might come from them as well in terms of treatment. So I'm wondering what you're hearing from the young people that you're working with, and what can we learn from them?
Thanks, Ritu. I love that you asked what we can learn from young people, because I do think that in all of these conversations about youth mental health, about the crisis, their voices are the most important and often the ones that are missing from the conversation. And if we really want to do what we're saying and meet youth where they're at and support their mental health, we need to start by saying, we see you, we hear you, tell us more. There's a lot that I've learned from my clinical work, and first and foremost, it's that young people, especially teens, deserve a lot more credit than we give them. They may not always know what they need, but they do know what they like and they know what they want. And in order to help them, we need to understand those things, because they speak with their feet, with their wallets, with their attention. And if there's one thing I've learned, it's that this is a no-nonsense generation. They want real, they want authentic, they want inclusive, and they want you to demonstrate that you really live and stand for the things that you say you stand for, because otherwise they can see right through it. And I'm honestly really proud to see a generation where that values alignment so front and center. There's a few things that I've learned from my work at BME about how we might leverage technology in new ways to reach teens. Because as Tom brought up, we need to rethink how we're delivering care, because the current system is not enough. It's not meeting their needs. So for a little bit of context first, BME is a digital mental health platform that supports all teens, whether they're struggling or whether they're doing well. We teach them skills for resilience, for coping, and also just how to navigate life by pairing what's good for them with what's fun and engaging to them. We have clinically informed video content, live chat-based coaching, interactive care activities, and then more support for teens who do need it. But we've learned a lot from our teen advisory board, and I think a lot of it can be applied to healthcare if we think a little bit creatively. So first of all, teens have a new level of expectation around immediacy and convenience. They want and expect support when and where they need it. and they want it right away and through their phones. And that's why, for example, we built asynchronous text-based coaching that focuses on skills, because as we know, teens have heightened emotion centers, right? But the brakes that live in their frontal lobes aren't yet fully developed until age 25. So that means they're more likely to have strong feelings that come and go quickly, that can't always wait, and that they can't always plan ahead for. So if we ask them to show up to an appointment in 2 days, for example, that's not meeting them where they're at, especially for the teen who's having a hard time with negative thoughts late at night, whose parents might be asleep, who doesn't want to go to the ER. You know, that teen needs real-time coping skills at their fingertips and outside of those 9 to 5 appointments that the system's currently giving them, which means, again, we need to get creative. And the last thing I'll share is this: we may not like how teens use technology, but they're going to use it anyway. So our best bet is really to lean into the parts of technology that they like in order to help them, but do it safely and with oversight and involvement of trained experts like clinicians and researchers. I do think it's possible to translate information from our clinical practices and deliver it in the form of, say, short form videos or features that remind teens of the other platforms that they do like. I've learned that at the end of the day, if you want to get through to teens, you need to be relevant to their lives. Simple, right? Not a tall order at all.
Thank you for that. That's incredible. You know, I've been doing a lot of stories on children's mental health and teen mental health, and I can't say I often hear about having teen advisory boards and sort of trying to, and you know, the conversation is so much about the negative impacts of technology on teen mental health, but how do we tap into what they want to actually help them? Thank you for that. I want to turn to Christine now. And, you know, Christine, most people who work with mental health, most people who struggle with mental health problems sort of know that stigma is a big issue in terms of seeking help. And that's especially strong in communities of color. So I'm wondering, Christine, if you can talk about what you see with your patients and how we might begin to shift norms to reduce stigma.
Stigma is huge, and I think we can't have a conversation about mental health in this country if we don't address stigma, because it's often the biggest barrier that makes it difficult for people to express whatever concerns or worries that they have about their mental health, and to be able to be fully engaged in care and various treatment options. What I often see in the clinic, where I primarily see Black and Brown patients in Boston, young people, is that there's a worry about having this label of having a mental health condition, while on top of having this label of being Black or brown in this country. It's hard enough navigating America with brown skin and having the added, for some, perceived burden of having a mental health condition is a really huge undertaking for a lot. And when I think about stigma, I think about it in two different parts. I think about there's a worry and fear of being treated differently, and a worry and fear that people are going to have negative attitudes and assumptions about you because you have a certain label. And so carrying this double minority kind of identification is really difficult. And so what I try to do when I'm working with people and they're talking to me about medication, which has a tremendous amount of stigma, I talk about how amazing it is that they are putting their health and well-being first, how that will attract positive energy from other people because they'll be able to be their best selves, to be productive, to be able to thrive out in society, how they'll be able to reach their full potential, and really highlighting the positive aspects of emotional wellness so that it shifts away from that narrative of people are going to view me negatively, I'm going to be less than. The idea and the hope of mental health care and mental health treatment so that you cannot be less than, but be your full, whole self. And it's a really tough sell, right? Because they have to actually land in my office for us to engage in that conversation. And so what I really hope that we can continue to do, and through some of the work through NAMI, the National Alliance on Mental Illness, is having this open dialogue, these ongoing conversations about emotional wellness, about the importance of prioritizing your mental health so that we can reduce that stigma and just continue to have these conversations out in the general public. It's so needed.
You know, we talk a lot about, I was going to say, we talk a lot about barriers to getting care and access to care. Stigma needs to be part of that conversation, right? We talk about cost and geography and not enough supply, but stigma is an internal barrier. I mean, everything Christine just noted it gets in the way of people actively feeling like care is for them or wanting to seek it even when it is in front of them.
Yeah.
Do you see that as much in kids, or do you think that this next generation is more open?
I think they're much more open. I actually think it's often their parents that get in the way and say, my kid doesn't want to see a psychiatrist or a therapist. And I say, actually, you know, your kid has been saying for a year that they are very open to it and would love to. Often it is our own stigma that gets in the way.
Yeah, no, the stigma is so important because it's sort of beyond, you know, it comes up so often in the conversations, even like workplace, right? Employers providing mental health care to their employees, but employees may not seek it out because they're the worry and the fear that Christine was talking about. I want to turn to Vikram now. Vikram, you lead a team that recently won the $10 million Lone Star Prize to improve access to depression care in Texas. And part of your solution involves building a new mental health workforce by training community health workers to deliver frontline treatments. Tell us more about that project and why you're hopeful it will work.
Thank you, Ritu. First of all, just to acknowledge, what a privilege it is to serve on this panel. So to answer your question, I'd like to bring into this conversation the global context and how this might inform the way we reimagine mental health domestically here in the US. I think we've already heard that even prior to the pandemic, the unmet needs for mental health care was large in every country of the world. It seems that no matter what a country is doing, no matter how much money they're spending, every single country has failed to shift the needle on the burden of suffering due to mental health problems. And to me, this actually points to a fundamental question about the very assumptions that underlie our approaches to mental health care. Tom describes this very beautifully in his book, the fact that we have tried to massage mental health care into exactly the same model that has been used in other areas of medicine. Now, I think expanding specialty service is needed, but this is neither sufficient nor necessary to comprehensively address the current and future demand of mental health care. And this is especially so for racial and ethnic minority groups that have historically been left out by specialty services or have not been treated in a way that they would actually feel comfortable with. Traditional models of care, Ritu, have typically focused on diagnosable mental disorders, which is useful for some, but it remains out of reach, unaffordable, and not timely for the vast majority of individuals who are actually needing mental health support. And this is where the innovation that we're taking to Texas actually comes from. The innovation is really built on this large body of science, which I consider perhaps the most important body of science in the mental health field today, that comes primarily from low-resourced, or what we used to call developing countries of the world. And the heart of this innovation is the harnessing of existing community resources to be involved with mental health care. Of course, in these countries, this is the only route available. But I will argue that, in fact, it is also the route that we should pursue here in the US. So what we're doing in Texas is really building on the EMPOWER initiative, which is a program of the Global Mental Health at Harvard initiative, which is converging three different strands of science. The clinical science that demonstrates the effectiveness of brief psychosocial interventions for a very wide range of mental health problems. The implementation science that comes mostly from the developing world that demonstrates the effectiveness of the delivery of these interventions by non-specialist providers such as community health workers, peer support workers, and so on. And of course, the pedagogical science, a lot of it just coming in the last couple of years, demonstrating the effectiveness of digital tools for training and quality assurance. So what Empower is doing is bringing together all of these into a seamless suite of digital tools, not directly to help people with mental health problems, but to actually build a community-based human workforce to deliver evidence-based psychosocial interventions. In Texas, our primary focus is the scaling up of behavioral activation treatment for depression. We're in fact rolling out our first community health workers in the summer of this year. But we're also working on a number of other mental health conditions, emotional disorders in adolescents, parent-child communication interventions for autism, all of which involve the delivery by routine personnel such as school counselors or primary care nurses. And I want to end by just saying something about something which is very exciting, and I'll encourage the listeners to go on to the website and type in Wellbeing Trust, Strengthen Us. And this is a new program that we've just about launched, which is to take the same approach, but to make it viral. And how do we do that? We do that by actually affirming the role of everyone in the community to support the mental health and well-being of others in their communities. Community-initiated care is what we call it. It blends not only the psychological science I referred to earlier, but also blends that with social connectedness. The idea that the care you receive from someone else who you identify with, and of course, Carlos spoke to peer-supported care. There's a lot in that therapeutic model, which is about social connectedness, that this is an equitable, efficient, and timely form of contextualized support to promote mental health, prevent self-harm, and of course, to help early interventions for mental health problems. And finally, I just want to read to, Empower is not intended to replace the mental health specialist care system. Of course, there's no one size fits all. We need to start with that, clear statement. Mental health problems are a dimension, and people need different intensities of care depending on where they are on the dimension. Empower is simply intended to expand the reach of the mental health care system deep into the community, not only addressing the vast unmet needs for quality care that people desire, but also reducing historic disparities in care. And in fact, I believe this is the critical way to address the stigma that is attached to mental health care.
We know that, even President Biden in his plan has talked about the need to expand the workforce because we know far too many people just can't even get to those specialists. So thank you for that. And this brings me to how do we cover efforts, these new solutions. Tom, you mentioned the clubhouse model earlier. Just yesterday, I think the health secretary was at a clubhouse here in DC for an event tied to Mental Health Awareness Month. So how would we need to restructure the financial incentives around mental health care to support these services?
Well, I think you've already gotten some great ideas. And I have to say, I love this conversation because what we're hearing about are lots of solutions. And we have too many conversations that leave you feeling kind of hopeless and overwhelmed. And the important thing to remember about the mental health crisis or the broken system that we have now is that almost all of this is fixable with what we know today. As Vikram said, this is all hiding in plain sight. It's really now a question of implementation and scaling, which we know how to do as well. I think that the challenge is going to be to changing the incentives. The incentives we have today, that the payer system, is all about the crisis, emergency room costs, hospitalization costs. I was meeting with someone this morning who told me a phenomenal data point that I'd never heard before, that the highest margin business at Massachusetts General Hospital, which I would have thought might have been their ICU or their neurosurgical or either orthopedics services, their highest margin business is their parking lot. The system that we have today is built around high presence, high utilization. It's filling up hospitals, it's filling up emergency rooms. That's how we get paid as a healthcare system. And that actually may be great for the healthcare system itself. It's not so great for patients and families. If you think back to what Carlos told us, almost no part of his journey required using that parking lot at Mass General or using the intensive care unit at a hospital. So I think we have to move the incentives. We have to figure out ways to shift what we pay for. I'm happy to say that in California, we're beginning that process through a waiver for Medicaid. It's called CalAIM, and it's an absolute transformation of how we use Medicaid, or we call them Medi-Cal dollars, for whole person care, to ensure that those things that you need for recovery are the things that we'll be paying for. It's still early days. All of this is just, at this point, getting out into the mainstream, but I'm pretty hopeful that by changing those incentives, by changing what we pay for, we can change what we mean by care and ultimately change outcomes. Because we know how to do this. We simply have to begin to implement. We have to basically begin to do what we know. And at this point, we haven't been doing that for the last 3 or 4 decades.
Just to build on what you just shared, Tom, I think we should also rethink what we consider prevention, right? So that those incentives and the payment models match. And just to add to some color to that, prevention is not just about meditation apps, for example. There's so many things that we can do to support everyday mental health, especially focusing on building the tools that we need and practicing those tools when you're feeling well, such that you can access them and successfully use them in the face of stressors that come your way. We could put into place universal mental health exams, the way we do physical exams, so we can catch these illnesses earlier. We know all of these things, like you said, there's models for it in other areas of medicine. It just whether or not this is an attainable goal depends on disrupting some of the current payment models, as you said.
One of the things that sorry, go ahead, Tom.
Well, I was just going to add is just to bring this home, in the current system, you have to get reimbursed. You have to have a CPT code, which means you have to have a diagnosis, which means prevention, by definition, is going to be very difficult to cover because you're trying to provide care before there's a diagnosis. So it's that kind of thinking that we have to begin to chase. And we're just not there yet, but we could be.
One of the things that I hear that all the time, Tom, from my sources, from providers, and one of the things that often those who work with children often tell me is that, well, as soon as a baby is born, we have a system set up for well baby checks. And so pediatricians do this. And so it shouldn't be that far of a leap to get us to include a behavioral emotional health screening along with these, kids are already going to pediatricians' offices. So it shouldn't be hard. We just have to get to the point where we actually cover it.
Hiding in plain sight, as Tom said.
Yeah, there's even a new model for this. It's called dyadic care. That's actually part of the new California initiative, which says that when you come for your well baby checkup, it's a well family checkup. We're open for business for not just the 6-week-old or the 6-month-old, but for mom and dad and brothers and sisters, that we're looking at the whole family. And I think, again, that's not so complicated. We don't need CRISPR and a new molecular marker for that. We simply need to open our arms to what is compassionate care for whole families.
I have to say, some places I think are doing it already. Like when my son was born, I think up until he turned 6 months, I took a depression screening. So some places are doing it. And so it's not, it's not going to be that much of a leap to sort of keep doing that and do, say, go to what California is doing now. Vikram, I'm sorry I interrupted.
No, I was just going to sort of, amplify what, we've just been hearing about early life interventions. I mean, I think one of the most important targets for prevention has to be years before the mental health problem begins. Our view on prevention isn't just about, whether it's got a diagnosis or not, but when is the best time to prevent? Given that the single most replicated risk factor for poor mental health, and this is across all mental health conditions, is adversities in the first few years of life. It's quite remarkable that our discussions on prevention still are about just before the illness begins, which is usually 15 years too late. I think there is, in fact, a real opportunity here. There is a huge movement globally on early child development. They're completely separate from all these conversations. They don't even consider what they do a mental health related activity. In fact, it is. What is early child development? It's a euphemism for brain development. It's about the healthy development of the prefrontal cortex, for cognitive development. And in my mind, one of the most important pathways between the observation of adversities in early childhood and poor mental health in later life is, in fact, through cognitive pathways. And so there is a real opportunity here. We don't have to reinvent the wheel. We just have to figure out ways in which we can break down the silos between these different disciplines and different communities of actors so that we can actually converge on a common goal.
You know, one of the places where I think we have the best data on prevention in like real time is preventing anxiety, depression in the postpartum period. So even moving a little bit earlier in child development to first and second trimester. The review that was done last year in Nature was really kind of stunning. I hadn't actually seen the numbers before, but it was a meta-analysis of something like 40 studies showing that overall there was a 50% reduction in depression and anxiety in the postpartum period by engaging new moms or soon-to-be new moms with screening and mental health care for those who needed it. And to quote Vikram, you know, if a 50% reduction, if you could turn that into a pill, it would be an absolute blockbuster. That's an extraordinary effect size. We just don't do it yet.
I think it's worth asking the question, isn't it, Tom, as you do in your book, why is it, I'll throw this question to you because you write about it, why is it that in spite of all of these amazing interventions, there is this feeling that we have very little to offer in our field? There's this kind of nihilism that prevails. You know, you guys haven't really got anything like compared to the other fields of medicine. And following on from that, why is it that we don't actually support and back this enormous range of interventions we have at our disposal?
Yeah, it's the right question. So, you know, when I say there's a 50% reduction, that's almost precisely the efficacy of the influenza vaccine, right? So we have a very effective vaccine. It's not as good as COVID, but it's certainly pretty good. So why isn't this being done? And why isn't it better known is a really interesting question. In some ways, it goes back to Christine's comment about stigma. And you know, for me, I don't like the term stigma because I feel like discrimination is a better term when it involves the individuals with mental illness. But the place where stigma really does seem to apply, where there's this kind of illogical, truly irrational, negative attitude or negative bias, is when we talk about the treatments for mental illness. And that's why I think Carlos's commentary is so vital, to remind us that people do recover, that prevention can work, that we have good tools to offer. There's no magic bullet, there's no cure, but when you put the different tools we have together, we have the ability to help people to recover. And a lot of what we're facing here is this sort of negative bias about the power of those tools, the effectiveness and safety of those tools, from medication to psychological treatments to all of these psychosocial supports that we've already been talking about. These things work, and we need to begin now to make sure people have access to them.
I feel like all roads really lead back to that reimbursement, right? For some of these models, which means, you know, if health plans are not reimbursing for some of these interventions that we know work, health centers and individual clinicians and the rest of us are not going to be incentivized to move toward it. And that's probably the first thing that needs to change, because like we said, we know how to do proactive evaluations. We know the value that it might bring. We just need the payment models to catch up to support it. And I wonder if stigma plays a role even in key decision makers across all of these systems.
So can I actually turn to Carlos? Carlos, I wonder if you have any thoughts on sort of stigma and bias, and like whether you've ever faced it and what you've seen, how you've seen that play out with others you work with.
Absolutely. Well, I think it's important to differentiate that there's, you know, the external stigma one faces, the discrimination people face when they disclose or choose to share their lived experience. And there's also the internalized stigma. You know, I had my preconceptions of what it meant to be someone living with a serious mental illness like schizophrenia, and that at least initially during my diagnosis didn't involve work, it didn't involve graduate school, it didn't involve meaningful relationships. But fortunately, if there's an antidote to stigma, it's storytelling. It's the sharing of narratives of people that are living well with serious mental health conditions, and the sharing of hope. And for me, that has been through family members and through caregivers and through friends that held expectations and a vision beyond what I saw for myself, especially initially early on. They saw a future for me that I couldn't initially see due to the fog of stigma and so forth. So it's so important to share hope with others early on in their journey.
And Christine, I'm wondering what you've seen in your work in terms of, how helping people you work with find kind of the social support and have that help with the stigma as well.
I think it helps because when they have that social support, it makes people feel like in those moments and those interactions, they are being truly seen for their whole entire selves. And I think for so long, for so many people, they have to kind of live in the shadows of their mental health condition, that they feel as though they can't be their full self because there's this other part of them that they hide away from others. And it makes them feel more alone, more disconnected, more isolated because they really can't be their full authentic selves. But if you have that social support coming from a community of individuals who know exactly what you're experiencing, who have the tools to be able to best support you during times in which you may be experiencing more acute episodes. Being able to lean on people can be incredibly encouraging because it allows you to think beyond yourself, to realize that you truly have an impact that exceeds beyond your body. And that's truly powerful when you're able to connect with people in that sort of way. So it's one way to give people hope. It's one way to be fully seen. And it also helps to melt away some of that stigma. And again, stigma with the fear of discrimination, that fear of being treated differently. When you have these connections and they're treating you positively, they're uplifting you, that stigma, it melts away, that both internal stigma, and also hopefully it helps to address the more externalized version of stigma. So this community that's supporting you can also hopefully support other people by the type of language that they use when they're talking about individuals living with mental health conditions. When they are reaching out and offering up support and asking people the question, how are you today? But asking it in a meaningful way, asking it in a way in which they actually want to hear the answer and they care about the answer. So support this community is so important, and that's just one other way to reduce stigma.
Hey,
I love everything you just said. Sorry, go ahead, Tom.
Yeah, I mean, Christine, I had the advantage of chatting with you about this last night, and you made, I thought, a fantastic comment, which I hope you'll share with others, because I think a lot of people need to hear this. You talked about hope and your role as a purveyor of that. Could you unpack that a little bit for this group? Because it was a beautiful thing that you said.
Thank you for that, Tom. Because I really think if we are talking about mental health, looking forward into the future, we have to talk about hope as well, right? And what is important for all of us who are on this journey of ensuring that people have better access to mental health treatments, to make it such that people are empowered with the knowledge and understanding about various mental health conditions. We also, as providers, need to instill hope in the people that we're working with, because it's a system that is so overwhelming and so complex that one can feel hopeless. They're already experiencing significant symptoms, but to have those symptoms and to have to experience this system, which is confusing even to me, that's too much. And so when I have the opportunity and the privilege to be able to meet with patients in my office, I talk about being on this journey with them and focusing on this journey towards recovery, and to let people know that it's a team effort. It's not just you patient, you do all the work and good luck and I'll see you in 6 weeks, but it's how can we work together? And sometimes it's hard for people to want to come alongside you and to engage in that process. But what I remind people is that I am hopeful for their recovery, even though they may not be able to see it right in that moment. I'm able to hold on to that for them. And it's the idea that I'm literally reaching down to them, stretching out my hand of support and guidance to them during a time that may be quite difficult and overwhelming. And my hope is that they just grab onto the hand so they can pull them towards that hopeful journey towards recovery. I know it sounds really optimistic and idealistic, but we need to think like that. And we need to operate like that when we are providing care to our patients.
Christine, I just want to say I feel hopeful just hearing you speak. I wanted to come back to something else you said about feeling seen and this idea of finding social support and where you can feel like your real self and find people to lean on. It's especially important for teens and young people, right? And just on that note, as we think about finding community for that young population, there is an important change to just be aware of. And it's that we used to think of communities as only being in person, as sports teams, school, church groups, et cetera. But the truth is, online communities are real to a lot of teens, and sometimes they're only support. So if we want to help support teens, we need to lean in a little bit into their definition of community. Pay attention to where they feel a sense of belonging, because the more we try to force teens offline, the more it seems to backfire, and we might be eliminating an opportunity for them to find places where they might feel seen. So instead, I think if we focus our efforts on helping teens find safe and supportive spaces online, instead of ones that are harmful to their mental health or ones that come with the risks of, say, social media or online forums, I think, part of one important part of the future of mental health support for teens will be creating those safe spaces online, creating those spaces where teens can be themselves, understand their strengths, lift each other up, practice communicating with others, develop those meaningful connections that Christine, you mentioned, and even learn skills that they can then take into their real lives in person, because of course we know that's important as well.
I also wonder if this applies to youth of color particularly, and communities of color as well. Like, are there opportunities to connect people to more support on the digital space? Christina, do you have any thoughts on that?
Yeah, so I think it's important part of this conversation, because I think over the last couple of years, it's been really challenging, especially for everyone, but for our youth of color, especially during the summer of 2020 with this national reckoning around race within this country, and young people hearing that people were against the phrase Black Lives Matters. And it's not that all young people in the country went to the Black Lives Matters website and looked up the mission statement. All they knew were the words. And they knew that people were against these words. And understanding and trying to understand and struggling to understand why it was that people didn't think that the lives of folks who looked like them and their family members didn't matter. And so to have that already on top of experiencing the pandemic, on top of kind of developmental challenges that one experiences socially, it's really been quite challenging and impactful. And to feel as though you had a sense of community with your peer group or with people in your school, but then hearing that perhaps through online presence, through some of their posts, that perhaps they were against Black Lives Matters, or they're kind of more openly expressing some of their political views and more blatantly kind of out there with regards to some of their racist attitudes and actions. That's a lot for young people to have to deal with. And so what has been really powerful is for people of color to have a space in which they could talk about their experiences and feel validated in those experiences. In addition to that, to not only feel validated by the support of people who look like them, but validated and empowered by the people who don't look like that. And to feel as though they're not alone in this kind of fight towards racial justice and equity, that there are multiple people who are joining along in these efforts. And so kind of expanding the community such that it's not just Black and brown folks, but it's everyone, because that demonstrates that we all have a shared sense of responsibility in ensuring that our children of color have the supports that they need. And I say all of this because we know that in recent years, the rates of suicide among children of color have just skyrocketed. And we're talking about young kids between the ages of 5 to 12. They're twice as likely to have suicidal behaviors compared to white children. So we really need to think about how we can uplift them, how we can support them, and we all can play a role in that, not just people who look like me, but everyone.
Thank you. So we are actually going to move to audience question now, and unless they ask specifically about from any particular panelist, I'll invite all of you to, anybody to jump in. So we have from Sanjana, the question is, what are some approaches to maintaining ethical principles when using digital platforms to deliver care? And that also makes me wonder about sort of the privacy issues. So Neha or Christine, do either one of you want to take that?
Sure. So this is, first of all, a very thoughtful question. And I think anytime a digital platform provides health care, they need to follow the same ethical principles that we do in healthcare. Where it gets more nuanced and potentially more important is when you're looking at digital platforms that are not necessarily providing healthcare services, but are in the healthcare adjacent space. And this is where a lot of the innovation is happening, right? So the good ones are still going to follow some of those basic principles, especially do no harm. So at BME, for example, we say we're safe by design. What does that actually mean? It means we're considering safety proactively in all aspects of the platform and policies. And this is probably the most important point, not because we have a legal obligation to do so, because again, we're not healthcare. The legal goalposts are not necessarily the same. But we recognize that teens who we serve, who are inherently vulnerable, will turn to us during times of need. And we feel a duty to do everything we can to protect them based on what we have. And that also means meeting privacy standards and making sure that we're not sharing any data, making sure that we're thinking about child rights where it's applicable, thinking about consent, adequately educating the user, and really just making sure that we're not taking advantage of them in any way.
Maybe I could just add to that briefly, because I've been deeply involved in innovation for mental health. And I have concerns about the ethical aspects of traditional care, but some of those carry over to this space. And I would agree with Neha that certainly privacy is hugely important. We do need to transform this space, but I often say that we need to change at the speed of trust. And trust is based not just on privacy, but on giving people agency so that these are services that they can manage and control. So this is being done by them and with them, not to them or for them. And that hasn't always been the case. I think we're learning as we go. There have been some missteps as we've developed the innovative companies that are trying to change the way mental health care is delivered. But I think ultimately we'll get it right. I tend to say that this is a 5-act play. We're in the first act. And there will be some times when we'll probably misstep. We'll have to learn as we go, but trust is going to be really critical to make sure this is successful.
I'm going to move to the next question, which is for Vikram from Karen. The question is the future of mental health tasks shifting care to the community through digital training?
Well, I certainly think it's one of the futures. I wouldn't say it's the only one, but let's remember that the one reason why none of these innovations have gone to scale is because of the enormous cost posed by traditional models of training and supervision, which typically mimic what happens in scientific studies, randomized control trials, where the emphasis is largely on ensuring fidelity for the trial. So you have experts who bring in health workers into a room, just like we have traditionally done before the pandemic. You have to fly in the expert from somewhere else because usually they're not available in that local community. You then have those health workers who are already doing something else take a week off or 2 weeks off their regular work, and you can see there's an enormous direct and opportunity cost. It's a 18th century model of training and supervision that we still use now. And so I don't quite see how that 18th century model is fit for purpose for scaling up. What's happened in the last 2 years has been transformative in terms of how we have learned new ways of actually making digital learning and peer support and supervision actually feasible, acceptable, and I believe very effective too. And so that is, in fact, in my mind, the most likely future. We're actually using this now already in India, for example, where we've started working in 2 states of the country with the Ministry of Health, training frontline workers called the Ashas, who are the largest community health workforce in the world. And finding that not only do they love this form of training, it's so convenient for them, but actually they also find that it's empowering them to be much more effective in their roles in the community. In another few months, I'll hopefully be able to tell you what our lessons are with community health workers in Texas.
Well, this takes me to the next question, which I think what you just said sort of answers this next question a little bit. And this question is from Julie. She's asking, high caseloads, low pay, and underappreciation from the public have led to huge burnout issues among mental health care providers. How do we address this issue? And it seems like what you're trying to do would lessen some of the burdens on those who are on the front lines providing mental health care now.
Well, no, I think maybe that question is more about specialist mental health providers. And I believe that that burden will continue and it has to be addressed as a separate issue. The approach we're taking is actually meeting the needs of the huge chunk of people who never get to a mental health provider in the very first place, or get to the provider in a stage of crisis. I mean, again, I'll paraphrase Tom, who says, America's mental health care system is a crisis care system. It isn't actually a mental health care system. Mostly it's moving from one crisis to the other. I find it, very interesting that one of the biggest innovations that is being announced is a crisis call line. I think it's necessary, but I think the metric of success must surely be that no one uses that call line. And I think that is how we should be really envisaging what our system should be, not supporting people in crises, but preventing the crisis from happening in the first place.
Does anybody else want to take the question about how to prevent burnout among frontline providers?
Well, just to say that this is a broader issue. I mean, it's true across healthcare. There's no part of healthcare which isn't experiencing an exodus of the workforce, and people are burned out. I think one thing that happens that's a little more unique to mental health is so much of mental health care is done in isolation. And so the opportunity to bring people together, that is to bring providers together to support each other, could be helpful. There's the beginning of doing that through some of the large companies that have now aggregated therapists. We're beginning to see that as one of the things that they can add to the assets that they bring into the therapy situation.
I just want to add on to that about burnout within the field, is that with all of the growing demands of taking care of so many patients, not having enough time in the day in the clinic schedule to be able to meet everyone's needs, there's also not enough time for some physicians to be able to address their own mental health concerns. And that may not only be an issue of time, but also an issue of stigma. I know we've been using this word a lot during this conversation, but there still is this concern about being viewed differently, being viewed in a negative way if you have a mental health condition, one that you're openly seeking treatment for, and your physician. There's still a lot of worries about that. And so just wanting to throw that into the conversation, especially if we're talking about burnout, if people can't address their own mental health needs.
Actually, this is a very good point, Christine. And that takes me to a question about how can we better address stigma around seeking mental health care in the workplace at large?
I think it all has to do with the types of conversations that are being had in the workplace and the modeling that's being provided by leadership. If leadership is leaning into mental health conversations by talking about what it is they're experiencing for the day. So starting off the meeting by saying things like, I just have to acknowledge the fact that I'm having a difficult day today. I'm experiencing some anxiety. I may not be 100% today, but I felt like it was important for you all to know. If you hear something like that from leadership, it really kind of conveys this message that this is a safe space to talk about mental health concerns and to also talk about some of the resources that are are being utilized within a company. If more employees can talk about how they access their EAP services, how they took a mental health day, then hopefully that will shift the culture within the workplace when talking about mental health.
I'll just add, we don't need more encouragement or suggestions as much as we need permission. We need things to be mandatory and default, where people can opt out if they're not interested rather than opt in, because opting in is still faced with that same stigma, right? If a manager says, instead, I'm going to check in with everyone once a month about their mental health or give you a mental health day. If you don't want it, that's fine. It sends a different message, like Christine said.
This is the last question, and it's from Tina for Tom and Carlos. It's, what hope do you see for therapeutics and current studies to help understand biological basis for serious mental illness?
Carlos, I'll let you go, and then I'll be the cleanup batter here.
Sounds good. I'll keep it very succinct. I have the opportunity to be part of the Accelerating Medicines Partnership for Schizophrenia, which is a public-private partnership that aims to develop new biomarkers to facilitate drug development in the period where people are at high risk for psychosis. And that, to me, is a cause of hope and optimism, knowing that scientists are working across sectors to work in what's been an underdeveloped space to get to new treatments that can really move the needle and prevent the disability and the outcomes that are often associated with psychosis.
Yeah, I'm pretty excited about that project as well. I think the kind of takeaway for me is we've been talking a lot about this new model, which is a kind of psychosocial recovery model, particularly for people with serious mental illness. But that shouldn't be to the exclusion of the medical model that Vikram and I both spoke to. I think it's the medical model by itself is not going to get us to where we need to be, but we need both. I often like to say that the problem is ultimately medical. The problem is a biological set of disorders. These are brain disorders, and we need to know much more about that. The solutions, particularly the solutions in the short span of time, are really much more social, environmental, even political, and we need to have both.
I so hate to do this because I could keep talking to you all for several hours, but we are out of time. But I want to thank you all for just an amazing, incredible discussion. And I'm definitely feeling energized by all the different solutions that you all are talking about, and hope we'll get to see them implemented in the coming months and years more widely. And I just want to add that if for our viewers, and thank you for the great questions from our viewers as well, and thank you for attending. I want to mention that if you or a family member needs assistance with a mental health or substance use concern, please reach out to the resources on this slide, National Alliance on Mental Illness at 1-800-950-NAMI, the National Suicide Prevention Lifeline at 1-800-273-8255, or SAMHSA's National Helpline at 1-800-662-HELP. Thank you again to all our panelists for this very important discussion. And to our viewers, if you missed any part of the program, you'll be able to view it on demand on the Harvard Chan School's YouTube channel. And thank you all for joining, and have a wonderful day.
Thank you.